Today, as you know, we are focusing on multidrug-resistant TB and its treatment. Thank you all for being on time, and I would like to introduce today's presenters. This is Dr. Jennifer Hughes of Doctors Without Borders, Médecins Sans Frontières, who works in South Africa. Jennifer will speak on treatment of multidrug-resistant and extensively drug-resistant tuberculosis. She will also cover the issue of using the new drugs. And I'm pleased to introduce Erika Lessem, Director of TB-HIV project of the Treatment Action Group. Erika's presentation is on advocating for improved multidrug-resistant TB treatment. And we suggest today first to listen to the two presentations and then ask your questions. And there are two ways. Either you will be unmuted to ask your question, or and you need to raise your hand sign, to use the raise your hand sign. Or you can simply type your question in the question section. Please check this out. This is on the control panel, just before the polls and chats. We thank you again for contributing to the slides by asking questions in advance along with your registration. And I need to note that this webinar is recorded, and the recording will be available online really soon. And please don't forget to provide your feedback on our webinar through the evaluation form. This is very important for us for further improvements. And welcome for those who are joining us. So I'm handing over to Jennifer Hughes.
Great, thanks, Evgenia. Hi, everyone. My name's Dr. Jennifer Hughes. I'm working with Médecins Sans Frontières for 7 years now in Kailicha, working on the drug-resistant TB program. So thank you to everyone for listening to me speak today, and I'm going to give a very quick overview, 35 minutes, of M and XDR TB, and talk about some of the new drugs which we're using in Kailicha, but happy to take lots of questions at the end to go into more detail about them. Okay, so let's start with the first slide. Okay, so the overview of the talk will be to just spend a couple of slides talking about the TB drugs that we use and the definitions of MDR and XDR, then to go over building treatment regimens and how we include some of the new drugs, and to give the last couple of slides to give you some idea of the experience we've had using these new drugs in Cape Town. Next slide, please. Okay, so from the registration list, I see that most of you are in the field of TB and drug-resistant TB, so this should be fairly basic science for you, but just in case there's anybody who needs some clarification, when we talk about first-line TB drugs, we're talking about the 4 well-known rifampicin, isoniazid, pyrazinamide, and ethambutol, which we treat for 6 months in total when we treat drug-susceptible TB. And that's 2 months of the 4 drugs followed by 4 months of the 2 drugs, RIF and INH. This fixed dose combination of drugs is very effective, and we see a very high cure rate among people who continue taking their treatment of over 85%. Next slide, please. When we talk about multi-drug resistant TB, we mean it's tuberculosis which is resistant, which we know is resistant to rifampicin and isoniazid at least. I know in our setting about 50% of our patients also have resistance to pyrazinamide and ethambutol, but we don't test for those drugs, so we don't know for certain whether our MDR patients have resistance to those. Next slide, please. Okay, so the treatment for MDR-TB is up to 2 years. Some people take it for longer, where you take pills every day and injections for at least the first 6 months. The medication that we have available for most of the people across the world are very old, they're expensive, they're very toxic, And of those who are lucky enough to even start treatment, only 50% or less are cured. Now, the treatment involves what you can see there on the left as what we call the second-line drugs, which includes the fluoroquinolones, injectables, ethionamide or prothionamide, and taururzidone or cycloserine, which are the same thing. Next slide, please. When we talk about XDR-TB, that requires resistance to rifampicin plus isoniazid, so MDR, plus one or both of fluoroquinolones and injectable resistance. Next slide, please. Now, XDR-TB is even worse in terms of treatment and outcomes than MDR. So we estimate around 15%, certainly in South Africa, of our MDR patients have pre-XDR or XDR-TB, and they have extremely limited treatment options available. So of those who start treatment, less than 20% are actually cured. So the drugs that we, until recently, have had available have been things like PAS, clofazimine, caprimycin, high-dose INH, and for those very lucky few, some of the new drugs, which we'll go into in a second. Next slide, please. Okay, so just to go over a couple of the principles of DR-TB treatment, and these are principles that we apply to treating TB of any resistance pattern. And we'd like to treat with preferably at least 4 effective drugs, or drugs which we think will be effective, plus pyrazinamide. One of the mainstays of treating MDR TB is to actively manage all the adverse events. So that's really aggressive management. What we found, certainly in our setting, is that if people are vomiting from their ethionamide or having pain from the injection or psychotic from the taururzidone, they just won't continue their 2 years of treatment. And so we really are quite aggressive about managing the symptoms, or if it comes to it, then substituting one of those standard second-line drugs for another drug if possible. Providing social and economic support is really key, because it's easy enough to diagnose somebody with drug-resistant TB, get them onto treatment, but then for 2 years, people have to be able to come to their clinic or find a way to take their treatment every single day. And so it's a significant burden on people's lives. And then the golden rule that most people are familiar with is that you never add a single drug to a failing regimen. So this is often confused with drug substitution, where if you have a patient who's 3 or 4 months on treatment and they happen to have a very severe adverse event, you can substitute that drug with just one other drug if their regimen has been working over that time. So if the patient's gaining weight, if their chest x-ray is clearing, if their sputums have converted. So if you're sure that the treatment is working, you can, with confidence, substitute one drug for another. If not, if the regimen is failing, you always need to add at least 2 or 3 new drugs. Now, the last point I put in italics and highlighted, because we used to say you have to treat for at least 20 months in total and continue for at least 18 months after sputum culture conversion. Sputum culture conversion we define as a transition from positive to negative sputum cultures, followed by another negative sputum culture at least 30 days apart. Now this, next slide please. Now this used to be what we said, but recently you'll probably be aware that the WHO have recommended the short course regimen. Okay, so I'm just spending 2 slides on this. This is not the basis of the talk, but I just wanted to mention it in case it comes up in the questions. So this short course regimen that the WHO recommends is based on data from a number of countries that followed on in the footsteps of Bangladesh, where they found that they treated with 9 months of a clofazimine containing regimen and had really great success rates in a select portion of their population with MDR-TB. Now, from the data that became available from countries who are using it subsequently, they made these recommendations that in patients with RIF-resistant TB who have never been exposed to second-line drugs in the past and who you can be sure don't have resistance to fluoroquinolones and second-line injectable agents, they could benefit from a shorter 9 to 12-month regimen instead of the conventional regimen. Note, though, that this is a recommendation that is based on very low certainty of evidence. Next slide, please. So this is what the regimen looks like for those who are interested. Essentially, it's a variable intensive phase of 4 to 6 months, including an injectable agent, a fluoroquinolone, prothionamide, clofazimine, pyrazinamide, high-dose INH, and ethambutol, followed by a fixed continuation phase of a fluoroquinolone, clofazimine, pyrazinamide, and ethambutol. Now, this is recommended also for HIV-infected patients and adolescents over the age of 14 years, but it's really recommended that we exclude resistance to the second-line drugs in order to assure that this will have a positive outcome. So the WHO did publish answers or recommendations to frequently asked questions about implementation of the regimen. So if you'd like further information, I suggest you refer to that resource. So that's all I'm going to say on the shortened regimen. Okay, next slide, please. Okay, so this should be familiar to lots of you, and those who are up to date will know that this WHO grouping of drugs, so groups 1 to 5, is now quite outdated. So just click again, please. And this is the grouping that a lot of countries use. Next slide. That a lot of countries use to build their standard regimens for MDR-TB. So I'm going to give you the example of South Africa because that's where I am. But if people have questions about the standard regimen in other areas, I know that there are lots of people listening who have extensive experience of DRTB in other regions, so they might be able to also contribute. So in the Western Cape, where we are in South Africa, the standard regimen that we use once a patient is diagnosed with RIF-resistant TB is to start them on a 7-drug regimen, including an injectable, a fluoroquinolone, ethionamide and high-dose INH, taururzidone, which is the same as cycloserine, PZA, and ethambutol. We often add ethambutol because 50% of our patients are going to benefit from it, and it's generally fairly well tolerated and it's cheap. But it is the first one that we drop if patients are struggling with the pill burden. And if we think it's going to affect somebody's adherence to treatment, then we certainly leave it out. What we do in South Africa, which I believe is slightly unusual, having spoken to other people from other areas, is that we drop we choose either ethionamide or high-dose INH, depending on what the INH mutation is. So if our line probe assay indicates that there is resistance to isoniazid, we can get the details as to which mutation it is. Very rarely it's both mutations, but it's usually one or the other. So if there's a CAT-G mutation present, then we include ethionamide, but we drop the high-dose INH because the CAT-G mutation confers high-level INH resistance. If it's an INH-A mutation only, then there's likely to be quite low-level INH resistance, which could be overcome by higher doses of INH. So in that case, we drop the ethionamide and we use high-dose INH instead. The reason it's one or the other is because ethionamide and isoniazid work on they have a common pathway at the end in their mechanism of action. And so using both of them together doesn't have an additive effect. It's only one or the other that's working. Okay, next slide, please. So the South African government based the standard MDR regimen on the old WHO grouping, as I mentioned. But just recently, the WHO have, in their 2016 update on the guidelines for DRTB management, they've recategorized the second-line TB drugs into groups A, B, C, and D, where the group D, 1, 2, and 3 are sort of add-on agents which are not considered core to the regimen for MDR-TB. And the main differences you'll notice are that Linezolid and clofazimine have moved up the ranks into group C, so they're considered core second-line agents. And PAS, paraaminosalicylate acid, has moved down. So we only really use that in XDR or in salvage regimens. You'll notice that bedaquiline and delamanid, despite everybody's excitement about wanting to access these drugs, are still only in group D2. And this is because there isn't enough published evidence yet to add to the evidence load to bring them up into the core second line agents, unfortunately. So we need to be getting our bedaquiline and delamanid data out there so that we can improve the evidence base. Next slide, please. Okay, so I'm going to spend a couple of slides just on a couple of the new and repurposed drugs. So the first one, bedaquiline, was the first new TB drug in 40 years. It's a diaryl quinolone, and it inhibits the action of ATP synthase. So from the clinical trials and a lot of the experience that we've had in South Africa, we've noted that the majority of adverse events are fairly mild and not serious, and those include nausea, some arthralgia, and headaches. The only very serious adverse event is the QT prolongation, and that's not particularly common among the patients that we have on treatment here. The dose of bedaquiline is, you have to load it for the first 2 weeks, so you take 400 milligrams once a day, and then for the remainder of the 6 months, you take it 3 times a week, so usually on a Monday, Wednesday, and Friday. We usually treat for 6 months, but just in the past year or two, clinicians have been requesting extensions of this drug if they consider that it's still effective in a patient's regimen. Next slide, please. Okay, and you can go to the next slide while there's a bit of a delay. So these are the information documents that are available, and they're available online in soft copies, but you can request them from MSF if anybody would like them. So it's the WHO guidelines on bedaquiline, treatment action group produced a document a few years ago, and then there's the information for patients on bedaquiline. Next slide. Okay, so the next drug, delamanid deltiba, you know, what we've found here is that people are less thrilled about delamanid or less excited about it in our setting. I think people were quite desperate for new drugs by the time bedaquiline was coming along, and delamanid hasn't seen the same excitement, unfortunately. And I say unfortunately because there are some indications which delamanid kind of has an advantage over bedaquiline in some respects. Anyway, it's a nitroimidazole. It inhibits mycolic acid synthesis. It's quite a unique drug in that it is metabolized by albumin. So that's kind of just an additional component for monitoring purposes over bedaquiline, in that you just need to ensure that the patient has a reasonable albumin level to allow for metabolism of the delamanid. Otherwise it tends to have a risk of building up, and therefore you have a higher rate of adverse events. The adverse events that we tend to see are nausea and vomiting, and some people complain of dizziness. It does have a QT prolonging effect, but we notice that it's slightly less than bedaquiline. The duration is also usually for 6 months, and there's no loading dose this time. You take 2 tablets twice a day, in the morning and evening, with or after food, and preferably a fatty meal. We have been requesting extension in some situations, but that's not generally happening very much. Next slide, please. Okay, so again, the WHO again have issued guidance on using delamanid in the treatment of MDR. And the SWIFT Response Project, which some of you may be familiar with, which is a group of sort of community, like volunteers in the DRTB community who collaborate to add to the evidence base that's out there for using new drugs in MDR-TB, produced this update document on when and how to use Delamanid in MDR-TB. And then, of course, there's the Treatment Action Group's guide for activists to improve access to Delamanid. Okay, next slide, please. Okay, so just wanted to mention Linezolid. It's been quite a controversial drug, certainly in South Africa. Linezolid we started using a few years ago, and it looked like there was increasing evidence on the efficacy of the drug in DRTB. It does have quite a lot of adverse events, particularly in prolonged use, with severe anemia, as a risk, peripheral neuropathy, and less commonly optic neuropathy. Now, although these adverse events are fairly common, they're not very often very severe. It usually takes a while to get to the severe anemic stage, and you can usually, if you're monitoring well, you can see it happening gradually over time. And the same with the peripheral neuropathy, and these are usually reversible once you reduce the dose or stop taking the drug. So there's not very good guidance on the dose and the optimal duration. So usually we start with 600 milligrams once a day, but I know in some areas they reduce that to 300 depending on the weight, if the patient weighs below 50 kilos or if the HB is particularly low. You can continue for 6 to 12 months, and some people continue Delamanid throughout the course of treatment for 2 years. Next slide, please. Okay, so obviously one of MSF's roles is to advocate for improved access to new TB drugs, and I know Erika's going to be talking about that after my presentation, but just to note that although we have good evidence for the efficacy of these drugs and increasing evidence on the safety of these drugs in MDR patients, only 2% or less of DRTB patients actually have access to these new drugs. And there are quite a lot of challenges in accessing them, mainly cost, and also things like having the drug registered in a particular country, or just having the supplier provide enough of it, such as in the case of clofazimine. Next slide, please. Okay, I think there's a question coming about whether these slides will be available afterwards, and yes, they will be. Okay, just to share a little bit of experience of the Linezolid battle that we had in South Africa. So for many years, Pfizer, the drug company, held a monopoly on the Linezolid sales in South Africa, and there was no registered generic. And so the government, through the government tender price, the government was paying 20 euros per tablet for 600 milligrams. Through the private sector, which is what MSF had to purchase the drug through, in South Africa, we were paying 50 euros per tablet. And remember, a patient is taking 1 tablet per day, potentially for 2 years of treatment. So that was a huge cost to MSF when we first started using Linezolid here. We advocated and lobbied for a reduction in that price by Pfizer, as well as registration of a generic alternative. And finally, Hetero, the generic drug company, managed to register their product in South Africa. And as soon as it was registered, Pfizer promptly reduced their price to less than 7 euros per tablet, and were then awarded the government tender instead of Hetero. So still having a monopoly on the drug supply in South Africa. Okay, next slide, please. Okay, so that was kind of the overview of TB drugs and regimens and new drugs, and I've got a couple more slides left, and I'm just going to share some of the experience we've had using the new drugs in Cape Town. So next slide, please. So I'm just going to, in the next slide, I'm going to explain to you exactly where Khayelitsha is and how it relates to Cape Town and the Western Cape and South Africa in general. Okay, so you can see in the top left corner there is a picture of Africa. South Africa is right at the bottom. In the top right corner, that's South Africa with all of the different provinces, and the Western Cape province is highlighted in red. So down in the bottom right corner, you'll see that these are the different areas, so the different regions of the Western Cape province, and the one circled, number 1, is the Cape Metro, so that's where Cape Town is. The bottom left block is the Cape Metro area, and circled is a tiny sub-district called Khayelitsha. So Khayelitsha has about nearly 500,000 people population, and so it's fairly densely populated. Next slide, please. Okay, just to give an idea of numbers, just from 2010 through to 2015, this is an indication of the numbers. So this is in the Cape Town Metro, so it's just that tiny small bit where Cape Town is, that part of the Western Cape. So these are the numbers of the blue in the bars are MDR cases and the pink is XDR. So in 2015, there were over 1,100 cases of drug-resistant TB diagnosed, and 194 of those in that year were from Khayelitsha. Next slide, please. Okay, so this, to give you an idea of the breakdown of the resistance patterns, so this is 2015, but the 2016 data is fairly similar. So of the nearly 200 patients that were diagnosed in Khayelitsha in this year, the majority of them were MDR. Some of them didn't have confirmation of their gene expert results, so they were just RIF resistant, and a couple of them were presumed, so we didn't have bacteriological evidence. Those were children who were started on treatment. We had quite a high proportion of RIF mono cases, and then the rest, so 16% of the MDR cases had any second-line drug resistance, so resistance to a fluoroquinolone or an injectable or both. Next slide, please. Okay, just keep pressing through 4 times, please. So just to give an indication as to when we use the new drugs, so when I say new drugs, I mean Linezolid and bedaquiline and delaminid. So in situations where we have both INH mutations, where we can't rely on either ethionamide or high-dose INH, that leaves us only 3 effective drugs. So that would be the injectable, the fluoroquinolone and taururzidone, along with PZA and ethambutol for what they're worth. So what we've noticed is that if you have a case with both INH mutations, in the majority of cases, these turn out to have XDR-TB. So we tend to have a delay in getting our second-line results after our first-line LPA. And so if we see both mutations, we have a high suspicion of XDR-TB. In cases where there is any second-line drug resistance either to the injectables or the fluoroquinolones or both, we then can't rely on one of kanamycin or moxifloxacin or both of them, and so they would be eligible for new drugs. Now, the biggest proportion of our patients on new drugs are those who are intolerant to one of the drugs in the standard regimen. So that would be cases where patients have hearing loss or renal impairment or electrolyte wasting, or who are just generally intolerant of the injectable. So that's when there's severe pain. You know that we have quite a high HIV co-infection rate in our cohort. Over 75% of our patients have HIV, and so they're often very thin, very wasted, and it's very little muscle mass, so they have quite a lot of pain when we're giving them the injections. Some of them get abscesses on their buttocks, and in children it's particularly cruel, I think, to give the injectable, and so we try to replace the injection with a new drug for them. In patients who are receiving taururzidone or high-dose INH, there's a risk of psychosis and epilepsy, and aggravation of epilepsy and psychiatric conditions. So we tend to try and avoid those 2 drugs and give replacements. And then in some cases where there are the severe hypothyroidism due to the ethionamide pass. And then a smaller proportion of patients are those where standard MDR treatment or individualized XDR treatment has failed and patients require a salvage regimen. Next slide, please. So just to give an overview then of the medications we have available to us. So in the top left are the drugs that we have available in the standard MDR regimen, and then the drugs below that, the bedaquiline, Linezolid, clofazimine, delamanid, PAS, are the drugs that we have available to substitute into that standard regimen for MDR patients. For patients with XDR TB, the regimens usually comprise of a combination of some or all of bedaquiline, Linezolid, clofazimine, delamanid, and PAS. And beyond that, if a patient's treatment for XDR TB has failed, then we have very few remaining options. We've just started accessing carbapenems, but we can only access meropenem, which has to be administered intravenously 3 times a day. It's really expensive, and it's quite difficult to manage patients with an IV port as an outpatient in Kailicha. We are starting to assess more people for surgery to see if we can get lobectomies or pneumonectomies for them. And beyond that, if nothing else works, then we treat patients palliatively. Okay, next slide, please. Okay, so I'm just giving you an example here of a patient who might present to us. So the patient presents, so you can just keep clicking through so the whole slide comes up. So we have a patient who presents with TB symptoms and they're required to give sputum for analysis. The sputum comes back a couple of days later. The result comes back showing it's gene expert positive and RIF resistant. So they start the standard MDR regimen. We then wait a week or so, or a couple of weeks. Sorry, just go back one. Now it's given away the story. Okay, so yeah, so the sputum comes back culture positive, confirmed to be RIF and INH resistant on the first line probe assay, and indicates that there are both INH mutations, with the second line DST results pending. So in that situation, ethionamide and high-dose INH are removed. Patients hate those drugs, so we remove them and they're very happy. But then that leaves a regimen with only really 3 effective drugs. So the injectable, the fluoroquinolone, taurursodone, and then PZA ethambutol for potentially what they're worth. So we applied for addition of bedaquiline and clofazimine, and we routinely switch the moxifloxacin to levoflox, but I know in some settings people have continued to use moxi because feeling that it's potentially better than more efficacious than levoflox. So whilst we're still waiting for the second line DST result, we're treating with at least 5, what we think are 5 effective drugs plus PZA and ethambutol. Still waiting on the second line DST result. So if we find out that the second line DST is susceptible, i.e. it's only MDR, then we'll stop the kanamycin and the bedaquiline after 6 months, and that means the continuation phase would have clofazimine, moxi, taurursodone, PZA and ethambutol. Next slide, please. Sorry, can you click down? Thanks. Okay, so what we found with this particular case is the second line DST result came back and showed us that there was resistance to amikacin but susceptibility to the fluoroquinolone. So we dropped the kanamycin given that it wouldn't work, and in this case this regimen would still be okay for pre-XDR TB because we'd have our 4 effective drugs, which is levoflox, taurursodone, bedaquiline, clofazimine, plus RPZN ethambutol. And next click. If this patient had been found to have TB that was resistant to Oflox as well, we wouldn't be able to rely on the levoflox anymore, so we'd have to add in another drug to ensure that there are at least 3 effective drugs in the continuation phase once the bedaquiline had been completed for the 6 months. Okay, next slide. I just wanted to give an overview quickly of a history of the access to bedaquiline that we had in South Africa. So what happened was in 2013, we started by setting up this national bedaquiline clinical access program. So it's kind of a unique program, I guess, in South Africa because South African Medicines Control Council doesn't allow for compassionate use. So compassionate use isn't kind of recognized in South Africa, I guess, but we were reluctant to try and access bedaquiline through a formal clinical trial because the trials were already ongoing here, and we were already getting really encouraging data from the trials. So this was prior to bedaquiline approval and registration in South Africa. So over the next year or two, we had 4 sites in South Africa that were approved for the bedaquiline clinical access program, so BCAP, and more sites were added later as we gained experience. So this allowed patients access to bedaquiline if they had pre-XDR or XDR TB, and Janssen were donating the drug for these patients through their compassionate use program. However, then in November 2014, bedaquiline was registered in South Africa, the fastest ever for a drug to be registered, I think, here. And then it became available from Janssen at 10,000 Rand, which is about €1,000 for a 6-month course. Next slide, please. So once bedaquiline was registered, the BCAP then expanded and was rolled out to a much wider set of clinics and facilities. So the phase 2 rollout meant that the provinces could then take that forward and train their clinicians and ensure that patients who were eligible for bedaquiline could receive it. So the eligibility criteria included pre-XDR and XDR, but also those with MDR who needed substitution, most commonly patients who were intolerant of the injectable, as well as patients with both INH mutations. And then phase 3 rollout occurred late 2015, so that allowed primary healthcare clinicians who were managing patients with drug-resistant TB in their clinics could apply for bedaquiline for a patient as an outpatient to be managed there in their primary care clinics. Next slide, please. Okay, so this is the just the standard application form that people used to apply for bedaquiline through the Department of Health. And so you can see there's a column on the left which says cases for provincial review. So that means the regular sort of quite straightforward eligibility criteria where patients who have pre-XDR, XDR, MDR for drug substitution or both mutations can access bedaquiline through their local provincial advisory committees who would approve these patients. More complicated patients where they've already had exposure to XDR treatment or there were very few effective drugs available, or children under 18 or pregnant women, or cases where MDR or XDR treatment has failed, those cases would be presented to a national committee which functions electronically, and cases are submitted by individual clinicians, and a group of experts can access them and provide advice and approval for bedaquiline and other new drugs such as Linezolid and hopefully delaminid in future. Next slide, please. So just to give you an idea of numbers, this was a breakdown of so remember the Western Cape, that's slightly wider than just the Cape Town region. So most of the cases were in Cape Town, but some elsewhere in the Western Cape also received bedaquiline. So over 1 year after we started rolling out bedaquiline to the wider provinces, we had a total of 420 patients started on bedaquiline in 1 year, and the majority of them were patients with MDR-TB for drug substitution, so the vast majority were patients who didn't tolerate the injectable, and then patients with pre-XDR-TB and a smaller proportion of patients who had XDR-TB. Next slide, please. So then delaminid has only just come onto the scene really in the past year for us. So it was registered by the European Medicines Agency, I think that's what EMA stands for, in 2013. And the WHO issued the interim guidelines in 2014. And at the moment, delaminid is currently accessible for South Africans, for the South African Department of Health doctors through Otsuka's compassionate use program. Luckily for us, down in our MSF project here, MSF, PIH and IRD had an agreement with Otsuka to allow access to delaminid under those compassionate use processes in some settings where MSF was and PIH was supporting projects. And now that MSF are purchasing the drug, we're able to use it slightly more widely. And soon it will be available through a delaminid clinical access program in South Africa, and that's just been approved this year, so hopefully that'll be rolled out fairly soon. The problem is delaminid has not yet been registered in South Africa. Now, Otsuka, the drug company who produced delaminid, they conducted the clinical trials here, but they don't have a South African office, I guess, to facilitate the registration and distribution of the drug here. So that's really our advocacy priority at the moment, is to try and figure out when that's going to happen and push them to submit the application for registration so that the drug will be more easily accessible after DCAP has rolled out. So as with the bedaquiline access program, the delaminid one is going to rely on a donation from Otsuka until the drug is registered. Next slide, please. So in terms of the eligibility, what MSF are providing for patients only in Kailicha at the moment are for patients with XDR-TB, where we want to use it in combination with bedaquiline. So the thinking is that XDR patients currently have such poor treatment outcomes with the regimens that we have available that any new drugs which we know are efficacious against TB should be included in a regimen for XDR patients. We still have to apply for compassionate use, for approval to use it in combination with bedaquiline, and so that's through the MSF and TB group. But if South African doctors want to access that combination, they still have to do it through Otsuka's compassionate use program. In some cases of pre-XDR, where there's resistance to the injectable, we might choose delaminid instead of bedaquiline. If there are MDR patients with a high risk of a poor outcome, such as patients with diabetes, with HIV and a low CD4 count, patients with extensive bilateral disease, we could be adding delaminid to their standard regimens. We don't do that as often yet, just because of limited capacity really in the project. And then anybody who needs a new drug for substitution, but where bedaquiline is contraindicated. So that might be if there's been previous exposure to clofazimine for more than 2 months. So the concern there is the cross-resistance between, or potential cross-resistance that may have developed between bedaquiline and clofazimine. So I think it's the mutation in the efflux pump, which also affects bedaquiline. If the patient's baseline QTc interval is over 450 but under 500, then we might prefer to use delaminid rather than bedaquiline. Bedaquiline hasn't been used or tested in patients under 18 years, whereas delaminid has, and there's emerging evidence for that group, and so we tend to prefer delaminid in those situations. Now, the next one is the biggest indication for us. So we have a lot of people who are HIV positive, and they're on the fixed dose combination, which includes efavirenz in our setting. And for patients who are stable on their efavirenz regimen and the viral load is suppressed and happen to be diagnosed with drug-resistant TB and need to get new drugs, we prefer not to change their ARV regimen if possible, and so in that case we might choose delaminid rather than bedaquiline. Bedaquiline cannot be used with efavirenz, but delaminid can be, so that gives it the advantage there. Patients who are pregnant or breastfeeding, we'd choose delaminid over bedaquiline, and then if there's any bedaquiline withdrawal because of an adverse event, we can have delaminid as an option. Next slide, please. I think I've only got 2 slides left now, so not too long. Okay, so just numbers then. The circle in blue on the left are the patients that we've started on bedaquiline, or not just MSF, but this is through Department of Health. So 208 patients started on bedaquiline, 189 of them only on bedaquiline, as in without delaminid. And then the pink circle are patients started on delaminid to date. That's 73 in total, 54 of them only on delaminid, as in without bedaquiline, and then 19 of them are a combination of both drugs. Next slide, please. Okay, so just looking at the combination patients particularly, because those are the ones that people are worried about. So this was a little bit outdated from a couple of months ago, but of 19 patients who started treatment with the bedaquiline delaminid combo, and that's for more than a month on the combination, 14 of them have completed 6 months of treatment. So of the ones that didn't complete, 1 patient died after 6 weeks and 4 are still on treatment. They haven't yet reached the 6 months. Of those 14 who completed 6 months, 9 of them had a combination, had an extension approved beyond 6 months. Now, of those 14 that completed the 6 months, 11 of them were culture positive at the start of the combination. 3 of them had negative cultures at the start. And then by 6 months, the majority of those patients had culture converted and remained culture negative. Next slide, please. Okay, so when to stop? We usually stop after 6 months, but sometimes people miss their tablets in a little bit in between, a couple of days here and there, and so we continue beyond the 24 weeks if some doses are missed. So we complete that full course of 188 tablets for bedaquiline or 672 tablets for delaminid. If there are occasions where the culture conversion is delayed or there's a slow response to treatment, we might consider extension of bedaquiline and delaminid, but we don't have so much experience with that yet. And we do need to get approval from our various regulatory authorities and from MSF and Otsuka. And, you know, I think there's an argument for continuing bedaquiline and delaminid in patients who are doing well on that treatment. We have evidence for these drugs working against TB, but we have no evidence for the drugs that we use in our standard regimens. So it kind of seems a little bit counterintuitive to stop the effective drugs and continue with the less effective ones. But I guess that's an argument for another day. I think that's the end of my presentation. So the next slide should say the end, and then we'll be on to Erika.
Hi, everybody, and thank you so much, Jennifer, for that great overview. You packed a lot of information into that, and just for people on the call who want to make sure they understood everything, I have some resources listed at the end of this presentation that kind of explains a lot of what Jennifer presented. So if it went a little bit fast, don't worry, and we're of course always here to answer questions. I'm going to try and keep this part of it brief, mostly just to give you guys some ideas about where I think, some of the priorities for advocates in terms of improving MDR-TB treatment are, and then we'll be sure to leave lots of time for questions and answers at the end. So Kristen, if you can go to the next slide, please. For those of you who were on the diagnostics webinar last week, this slide will look familiar, but I just want us to keep it in mind that access to treatment is a human right. This is something that everybody in the world should have, and it's an obligation of our governments to respect, protect, and fulfill our rights. And access to appropriate TB treatment, it falls both under the right to health and the right to the benefits of scientific progress. And this includes the principle of equity. So it's not just that we have to give treatment to, the easiest, lowest hanging fruit kind of patient, but this also includes vulnerable and marginalized groups. So people with HIV, children, who often can, for lots of different scientific reasons, be more difficult to diagnose and have more treatment complications. But it's just as important, if not more important, to ensure that they have access to treatment and good quality care too. And unfortunately, we're really not doing well on this at a global scale. The last WHO report indicated that only about 20% of the estimated new cases of MDR-TB were started on treatment. So this means that 80% of people with drug-resistant TB are not even getting treatment. And we know from what Jennifer just presented that a lot of patients, even once they're started on treatment, aren't getting cured. But the truth is we're not even starting them on treatment in the first place. So we're missing, about 400,000 cases a year, even just putting them on treatment. And then of those who get started on treatment, about half of them wind up getting treatment success, cure, or at least successful completion of treatment. So we're doing really poorly, and I think it's on us to really pressure our governments as well as the companies and drug sponsors to help make their products more accessible. Next slide. Next slide. So before we get too much into the access issues, I just wanted to highlight that research should really be something that's on all of our minds. First of all, we need to understand better how to use the drugs that we do have right now. Most of the recommendations that we have for how to use these treatments are just based on clinical experience. They haven't really been evaluated in properly randomized controlled trials. So we don't even know a lot of the answers about the drugs that we have right now, about how to use them best. But we also really need to work on drug development to getting shorter, simpler, and easier to tolerate treatment for TB. I mean, part of the reason it took Jennifer the amount of time it did to get through the treatment options is that it's really complex. We have a lot of different choices, but almost none of them are good choices. So we need to have, a simpler regimen for MDR-TB. It needs to be easier to tolerate, and then we'll actually, really help patients adhere to their medicine throughout the whole course of treatment, become non-infectious and unable to pass the TB on to other people. We've actually been seeing new data in, especially coming from South Africa, that most of the extensively drug-resistant TB that's being seen is just from strains that are really circulating in communities. It's not because people are not adhering to their medicine and developing additional resistance. For the most part, it's actually drug resistance being transmitted, primary transmission. So the best way to address that is really to put people on effective treatment and get them to be non-infectious quickly. So we need to find people earlier, but we also need better treatments to address drug-resistant TB. And to do that, the world is really going to have to step up the game in terms of funding drug research and development. You can see the very big gap that we have here in terms of financing for TB drug development. And we also need to step it up for basic science. Part of the reason that TB drug trials are, happening in kind of a limited way is that it takes a really long time to do them. You have to follow up patients for usually a minimum of 1 year, sometimes 2 years, to see if they relapse. And we need to have better biomarkers like we do in HIV. You can do, a viral load test and you can do CD4 counts. We don't have that equivalent in TB. You have to really follow people up for months after they finish treatment to make sure that the treatment really worked for them. So we also need to invest more in the basic science to be able to help all the kind of supporting things that need to happen for drug development. Next slide. So I'll go through this quickly, but I just wanted to flag for you guys that this is the result of underfunding for drug research. We have very few options in the pipeline. This year we got a couple more things coming into phase 1, which is good, but you can see from here we have just a handful of new drugs. This includes bedaquiline and delaminid, which to varying extents are already on the market. We have a lot of overlap in drug classes. There's a new drug called protominid being developed by the TB Alliance that some of you might be interested in. This is in the same class as delaminid, although we don't have a head-to-head comparison of the two drugs yet. And then Linezolid is an oxazolidinone, which is the same class as Linezolid that Jennifer mentioned. And the hope would be that this, preserves the really good antibacterial activity of Linezolid, but hopefully without some of the side effects. But it's been taking so long to get these drugs through the pipeline that we really still are a long way from being able to use Linezolid, for example. Next slide. And again, this is just another snapshot to see how we're doing compared to, the targets that have been set for drug development. And you can see that the number of new drugs and the number of early stage trials are lagging very far behind what the targets were. And this is really important because, we have some new combinations happening in phase 3, which is the kind of second to last line that you see here. But those are a lot of regimens, a lot of different regimens that really contain the same kinds of drugs, and they're just shuffling them around in different combinations. And this is still very important research. With the research that's going on, we hope to be able to further shorten treatment for drug-resistant TB, maybe down to 6 months, and hopefully just using 3 to 4 drugs instead of kind of the whole kitchen sink that we're throwing at drug-resistant TB treatment right now. But it's very scary to me to see the top 2 rows, and we see that there's really not that much new stuff coming down the pipeline. So once we figure out how to use bedaquiline and delaminid well in combination, and protominid, which is coming from the TB Alliance, there's going to be a really long time before we get new treatment options. And we know, from experience in TB as well as HIV that resistance does develop. It will develop for these drugs, and we need to have stronger regimens with other more efficacious drugs coming down the pipeline. Next slide. So getting into some of the access issues, I wanted to just start with the shortened treatment that Jennifer mentioned. So this was recommended by the WHO almost a year now ago, but most countries are still using the longer regimen. And my philosophy with this is it's still a lot of drugs. It's still not a perfect regimen. But if I were eligible to have the shortened regimen per WHO guidance, I would much rather have 9 months of crappy drugs than 2 years of crappy drugs. So I think we should really be pushing countries to switch over to using the shortened regimen in patients who are eligible. And we've actually heard some anecdotal evidence that a lot of countries are reluctant to switch because they have a lot of stocks of medicine right now, and they don't want to waste the drugs. And so instead, they're wasting them on patients. And so if you live in a country that, for example, gets Global Fund funding for drug-resistant TB treatment, you might want to consider working with the CCM and with your Global Fund program officer to get permission to switch over to the new shortened regimen. And it's okay to waste those drugs. It's much better to, destroy about $100,000 worth of drugs that are going to expire rather than force them onto patients who don't necessarily need them. The other thing that I think is important to highlight about the shortened regimen is that to be able to give it to patients Jennifer referred to this in her talk, but you really need to have good drug susceptibility testing as well as treatment monitoring. And so even though we're talking about treatment here, it's very intimately linked to the diagnostics question. So in all settings, there should be access to drug susceptibility testing. Anything that gets a positive, hopefully GeneXpert would be the first test up front, and you would find out pretty quickly if there was rifampicin-resistant TB. And if there was, that should get sent really quickly for a line probe assay, and that would be able to tell you if the shortened regimen was going to work for this patient. And you also need access to liquid culture to do treatment monitoring and make sure patients are on the path to cure. The other thing that I think would be important to highlight, and that's really not happening in most places, is that thinking through the treatment algorithms. So when countries do start to implement the shortened regimen, really what I think the flow should be, and hopefully this will become more clear in future guidance from the World Health Organization, but really what should happen is anybody who's eligible for the shortened regimen should get that. And then anybody who's not eligible for that should most likely get a regimen that contains at least one of the new drugs, and maybe more than that. This isn't very clear in WHO guidance, and I don't think it's been clear in country plans and national guidance so far. But this really is, how it should be. If the shortened regimen isn't working, it's because you need a more robust regimen with some of the new drugs. Next slide. I wanted to highlight this too. Some countries still are using what's called Category 2. And what Category 2 is it just adds streptomycin, which is an injectable drug, onto the standard first-line regimen. Usually this happens, if a patient has relapsed in their first treatment course. This is not a good idea. As Jennifer mentioned, we should never add a single drug to a failing regimen. And so if someone is, not cured from their first treatment course with drug-susceptible TB, it's really unlikely that just adding one crappy drug that's also very painful and has a lot of side effects is going to help it. Really, if someone is, has relapsed from their first treatment course, or they've just never been cured, or they interrupted treatment, they should get drug susceptibility testing and get a regimen that's actually tailored to their drug resistance profile. So if your country is still using Category 2, you should consider advocating for that to be removed, and it should be just standard drug susceptible TB treatment if they're, if it's the first time that they're being tested and they're rifampicin resistant. And then if that treatment doesn't work, they really need the full drug susceptibility testing workup, especially now that we do have better diagnostic options. Next slide. So I've listed here some of the kind of advocacy priorities from my perspective for the new drugs. For both bedaquiline and delaminid, I think we really need to be doing more to push our respective countries to incorporate these drugs into the treatment programs. For bedaquiline specifically, it's available for most Global Fund-funded countries through the Global Drug Facility, and it's actually available under donation. So for Global Fund-funded countries, it's free. The donation program is going to end in a couple years, so I think we should really be pushing countries to take advantage of this now, but we should also think about, an ideal price, a fair price for bedaquiline for once that ends. And I think that we should get rid of tiered pricing, and it should just be a flat, low price for all low and middle income countries. And if this doesn't happen, I think we should consider, pressuring either Janssen to voluntarily license out the drug to generics, or urge governments to exercise compulsory licensing and allow generics to produce the drug. But for this to be viable, we really have to, convince more countries to start using it. The demand for bedaquiline is pretty low, and literally Janssen can't give the drug away for free fast enough right now. And this is a shame, when we saw from Jennifer's data that only 2% of patients who are eligible for bedaquiline are getting it right now. So it's not that the need isn't there, it's just that we're not getting the drug out to people. So I think, the first step is really to get countries to start using this more. And then there are some additional research needs. We want to know, the optimal duration for treatment. As Jennifer mentioned, right now the recommendation is to use it for 6 months, but this is only because that's how long it was studied for. It's not because there's any reason potentially that bedaquiline couldn't be given for longer. And we need a bit more information on certain drug interactions, and also how this works in people who use drugs or alcohol and might have some liver toxicity issues. Next slide. So protominid, sorry, did we miss one? Was there a delaminid slide? Thanks. So delaminid is the other new drug. This has been WHO recommended for 3 years now, and barely anyone is using it. The sales globally have been around 1,000. This is crazy when we think about how many people potentially need it. And as Jennifer mentioned, even though there might be some more excitement around bedaquiline rather than delaminid, delaminid actually, under current WHO recommendations, has a much broader indication. So there are potentially even more people who need and would benefit from delaminid than bedaquiline. And I think, unfortunately, access has been limited and kind of demand has been limited because, A, countries feel that they have their hands full starting to roll out bedaquiline, and we should urge them, that it's not one or the other, that you need both. And sometimes you need both in the same patient, and that's okay to do. But also, I think that since bedaquiline had an earlier compassionate use program, and there's been a lot more familiarity with the drug, and Janssen has done a much better job registering bedaquiline than Otsuka has with delaminid, it's just not on countries' radars as much. So that's even more kind of onus on us as advocates to pressure our governments to be aware that this drug is important, that there's a lot of data to support its use, and that it should be widely taken up. As part of this, we also need to demand that the company register in all high-burden countries, and also all countries where it's conducted clinical trials. So, for example, the trials that led to delaminid's approval in Europe were conducted in Peru, and 3 years later, the product still hasn't even been filed for registration in Peru. We should also, make sure that the drug is available to all countries from the GDF. Right now, only a list of certain countries can access it, and the price is $1,700, which is high for a lot of settings. So we probably need to call on them to lower the price of delaminid. And as Jen mentioned, delaminid has been approved for use in children, and so this is really important. Kids are often, inappropriately treated, and this is a great option for them. There's going to be a pediatric formulation for kids, and this can really help eliminate the need for an injectable, which is really painful for kids, but also causes hearing loss and can permanently disable someone. Next slide. And I'm going to wrap up in about a minute so we have enough time for questions. Sorry, there was a slide on protominid. Can you go back to that, Christian? Thanks. Sorry, I don't know how the order got switched around. So protominid is in the same class of drugs as delaminid. It's still in clinical development. There's not a compassionate use program for it yet. But at CROI recently, some promising data from what's called the NICS-TB regimen were presented. And this was an open-label study, a very small study, so we don't have a ton of data yet. But it did look like in this population of people, mostly who had XDR-TB, some pre-XDR-TB, and some MDR-TB, that there was just intolerance to other drugs, that patients did very well on a very sparse regimen. Basically, it just contained protominid, bedaquiline, and linezolid, so 3 relatively new drugs. And patients have been doing pretty well on this, and it eliminates the need for a really cumbersome regimen. It's been given for just 6 to 9 months instead of really lengthy treatment. So I think we need to know more about this drug. We need the research to continue, but people might want to consider advocating for pre-approval access. And since this is a drug that's being developed by the TB Alliance, which is a not-for-profit, I think we'll also have to put pressure on donors to finance any kind of pre-approval access program. So I wanted to highlight, that there are some promising things coming down the pipeline. I think we have more tools at our disposal than ever to really treat drug-resistant TB. We have a lot of evidence that starting people on effective therapy rapidly turns them non-infectious and unable to transmit disease, and that people actually do very well when they get good treatment regimens. So we really need to stop, having excuses and allowing patients to not be started on treatment. And so we need to step it up in terms of pressuring both countries and the companies of these drugs who sponsor these drugs to make sure that they're accessible. So with that, we'll open it up to questions.
Thank you very much, Erika. So we have got some questions for Jennifer first. There are a number of questions on the use of bedaquiline. Bedaquiline loading dose is needed again. How many months after stopping bedaquiline? Jennifer?
So I was fortunate enough to be in a meeting with both Otsuka representative Jeff Hafkin and bedaquiline representative from Janssen just last week, and we were discussing these kind of questions, and the Janssen rep said that they tend to advise that if a patient has been off bedaquiline for more than 2 weeks, then they would restart the loading dose at 400 milligrams once a day.
Thank you. Next question is there any experience in the use of combination of bedaquiline and Lessem?
So there isn't that much experience because it's still quite a laborious process. You have to get approval through Otsuka's compassionate use program or through the NTB group. We have, like I mentioned, I think now, since if I was to update the numbers, it would be about 22 patients on the combination. I know that a couple of other MSF projects, such as Georgia, have patients on the combination. I'm not sure the numbers outside of MSF projects specifically. I know in South Africa as a whole, outside of MSF, there are probably a total of about 30 or 40 patients maybe across the country who have been able to access the combination.
If I could add to that too, there is a clinical trial underway by the U.S. National Institutes of Health AIDS Clinical Trial Group, or EATG, that is looking at a proper randomized trial with bedaquiline and dolaminid together. For people who don't know, the concern here is that they both cause what's called QT prolongation. So they both cause these kind of side effects in the heart that could be very dangerous, although we haven't seen much evidence of problems in kind of the routine use of these drugs. So we want to make sure that they're safe to use together, which is why the ACTG is doing this study. So we should have really robust data in probably about a year or two from this. But in the meantime, it's up to, I think, programs and clinicians to weigh the benefits and harms. And I think what we've been seeing is that, patients with drug-resistant TB who don't have other good treatment options are at such a high risk of dying that often it is potentially beneficial for them to get these two drugs together. So it's been great to see programs like the one Jennifer works at using these drugs, because there's we don't have evidence that they're not safe to use together, and for patients who are in really dire straits, they might benefit from having both of them.
Thank you. The next question is there any resistance to bedaquiline reported?
So I know just anecdotally that there have been cases of bedaquiline resistance. The problem, in South Africa, we've been lucky enough to have our NHLS National Health Laboratory Service looking at samples of patients who've been initiated on bedaquiline. It all started as part of the BCAP program a couple of years ago, and we were routinely sending samples through patients' treatment on bedaquiline up to the central lab in Pretoria, where they were analysing the samples. And the problem was they didn't know what the MIC level would be to conclude that a specimen is resistant to bedaquiline, and it was just through this surveillance over the past couple of years, along with the clinical information, that they could figure out what the appropriate level would be. And I do know, just from speaking to relevant people in the know, that there have been cases. I just don't know how many. We ourselves in Kalicha haven't had any specific reports of bedaquiline resistance developing, but I know that it has happened.
And the next one is one patient died from the group of combination of bedaquiline and delamine. Does it relate to the SE of combination?
So that was our, I think it was our fourth patient on, or our third patient on the combination, and he died just 6 weeks after starting the combination. He'd been on treatment, on second-line treatment, for a bit longer than that, but he'd actually deteriorated quite severely due to XDR TB, and he actually died of multi-organ failure, and potentially we suspected iris as well, because he hadn't long been on ARVs. He had multi-organ failure, severe renal impairment, eventually had hypoglycemia and died quite quickly. But from the monitoring ECGs that we were doing, we didn't see any QT prolongation, and we didn't suspect that it was due to any cardiac event, or particularly due to the bedaquiline or delaminid themselves.
There is a question about side effects. If patients got vomiting 1 hour after taking anti-TB drugs, do they need to take another full dose or half dose or anti-TB drugs the second time, or no need to take additional dose at all?
So, I mean, I don't know the scientific answer behind that, but I know that what we tell patients in our setting is usually if they vomit quite quickly after taking the meds, sort of half an hour to maybe up to an hour of taking the meds, then and they can see the medications in the vomiters, they're pretty sure they've vomited it up, then we ask them to take the dose again. But if it's beyond, it's kind of blurry, half an hour to an hour, so if they've left the clinic and they're on their way home and then they've vomited, we tell them to wait until the next day, and then just take their doses as usual after that.
And if I could add to that, when we're talking about treatment for drug-resistant TB, I think people often only think of the actual anti-TB drugs themselves, but there are a lot of other medicines that can help with these side effects. There are what's called antiemetics that can help reduce vomiting, and there are anti-nausea drugs. And I think we should consider this to be an integral part of MDR-TB treatment, and advocating for the availability of those medicines in addition to just kind of the anti-TB drugs themselves.
Thank you, Erika, and we have got a number of questions for you. Could you please explain this in short phase 2C concept and how it could be useful in future TB research and development?
Great, thanks. I see that the question's from Vim, and that's a really good question. This is a kind of relatively new trial design. So normally drug development happens in phase 1, where it's a small study. The first time it's in humans, then it goes into phase 2, and phase 2A would normally be for TB drugs, like a small, maybe 2-week study where you just look at the early anti-TB activity of the medicines. And then 2B would be when you give the drug for a bit longer, maybe 2 months or 6 months in combination with other drugs. And then normally it would go straight on to phase 3, and that would be a much larger multi-center clinical trial where you do very long follow-up times, and the main outcome, the main endpoint is relapse-free cure, usually at 1 or 2 years after the end of treatment. So there's a big gap between going from phase 2B, where you have kind of just a few months study, to phase 3, where you're investing a ton of resources. And as I understand it, the idea behind the phase 2C concept and why it could work very well for TB is that it's a smaller study. You're not investing as much as you are in a phase 3 trial, and you're not going for registration. But what you would do is, do the maybe have a study where the primary endpoint is about 3 months after to look at culture conversion. So you have the shorter term primary endpoint, but then you would follow patients up for the full kind of relapse-free cure afterwards as a secondary endpoint. And that way you could actually not only learn a bit more about how the particular regimen that you're studying would do before putting it all the way into phase 3, but you could actually learn about which endpoints help predict relapse-free cure in the future. So it would kind of inform the drug development science in addition to learning about the individual regimen that's in study.
Thank you.
We hope that more trialists start using this design for TB.
Thank you, Erika. And the next question is about the shortened regimen for MDR-TB. If shortened regimen for MDR-TB have strong evidence or of effectiveness, is it an issue of human rights if the country continues the long treatment even if the patient is eligible? This is to avoid waste, more patients could be enrolled in the Global Fund cohorts, and so on.
Yeah, I think this is exactly right. I do think it's a human rights issue. I'll say that, for the shortened regimens, we're still waiting for the randomized controlled trial. That it's called the STREAM trial, and we should have results in the next year or two from it. So right now, it's just a conditional recommendation from the WHO, but we do have a lot of observational data that support the use of the shortened regimen, and the longer regimen also doesn't have clinical trial data to support it. So we're kind of comparing apples to apples here. And so I think that it is a human rights issue. I think it would be a violation of someone's human rights to over-treat them with potentially toxic drugs if they are eligible for the shortened regimen. And I absolutely agree. To avoid waste, you could just enroll more patients onto treatment. Most countries are not treating even half of the MDR-TB treatment, MDR-TB cases that they have. So I absolutely think it's a human rights issue, and that we should be calling for switching over to the shortened regimen, while we still at the same time do, insist on actually developing the evidence base that we need to feel supremely confident in the regimens that we have.
Thank you, Erika. And another philosophic question about the approach. Please develop a little the idea of equity in the sense that equity doesn't mean equality. And our participant want to explain he worked in, or she worked in prison. She worked in prison, and guidelines say that the prisoners have the right the same services that people at large in the community. But equity means to give services to those more in need, more exposed, more at risk, and more underserved.
Yes, I agree. And I think the idea of equity, applies also to, patients who have drug-resistant TB more generally. They might need more support. We talked about this on the webinar last week for those who were on it. Patients with drug-resistant TB might need more support than a patient with drug-susceptible TB, for example. And similarly, within the population of people who have drug-resistant TB, yes, absolutely. I think it's important to be equitable and kind of support people in the way that they need support. There's excellent work that's been done by Partners in Health working with the local program in Tomsk, Russia, where they went into prisons and, also treated people in the broader community, and depending on people's needs, really tailored services to them. So some people might, need treatment support and have someone come and help them take their medicines every day. Some people might need transport. Some people might need counseling. Some people might need nutritional support. Whereas some people, are doing okay, and they just need to have their medicines and have, some proper treatment counseling for them, and then they'll be adherent on their own. So I absolutely agree. I think people who are living in congregate settings are at much higher risk of having TB. They're also probably at risk of having a lot of other comorbidities that might make them more susceptible to TB. And they probably need a lot more support. So yes, I think at a minimum, people in prison should have the same services that people do in the larger community. But they might often need more than that. And we've also seen, there might be cases of certain settings where there's a lot of transmission of drug-resistant TB. And so there might be a need for, more routine screening, for example, just to even find out who has it. Or there might be considerations about starting people on preventive therapy if they live in a setting very close to someone who has drug-resistant TB, even though this might not be the recommendation for the broader population.
Thank you very much. There is a question. How many countries have already given approval, stated using Delamanid's pediatric formulation for children TB? And what kind of countries is that? Are there?
Yeah, so the pediatric formulation is actually still being tested. Right now, Delamanid is approved, it's WHO recommended for use down to age 6, and that's using actually the adult formulation. But they do have a pediatric formulation that's under development, and hopefully, we'll have data on that in the next year, and so that could go up for approval also. So in terms of how many countries have started using Delamanid for children, I don't have the number off of my head. It does sound like in some programs South Africa has been using it, although I don't think that's in the treatment guidelines. Maybe Jennifer could say more about South Africa. But I think in general, uptake of Delamanid for adults or children has been very low. And I think it's probably even lower for children than for adults.
Yeah, absolutely. From our experience, people just get so scared about treating children with drug-resistant TB, new drugs or not. So we're fortunate here in the Western Cape to have on-tap access to Professor Simon Scarf, who is quite a seasoned professional with regards to pediatric drug-resistant TB, and he tends to try to access Delamanid as much as he can for patients who he thinks it might be effective for, but again, numbers are very small. I know that we've helped to access Delamanid for him for some of his patients who are admitted in hospital. I don't know this for certain, but I doubt that many people across the rest of South Africa are accessing the drug for kids. If Jen Furen is listening, she, I know, would have more updated information on exactly which countries they're using Delamanid in kids currently, but it's very, very little.
Thank you. From the whole complexity of TB treatment, even for drug-susceptible TB, what usually is forgotten is how to communicate this to the patients and families. That was a thought shared by one of our participants, Erika and Jennifer. Do you want to address this thought?
Yeah, I think. Sorry, you can go ahead, Jennifer.
No, you go first, Erika. I'll go after you.
I think that this is one of the fundamental problems of TB treatment, is that we don't spend much time on communicating to patients, doing kind of the patient counseling and education. And I think that this is an area where TB really needs to learn from HIV. The focus on TB is so much on adherence through directly observed therapy. And there's been actually a lot of good research that showed that people who have HIV and MDR-TB are preferentially adhering to their HIV treatment over their DRTB treatment. And part of this is because the DRTB drugs are awful, but part of it is also because it's a very top-down approach to TB treatment. It's hyper-medicalized, and people aren't, empowered to understand about the treatment, why it's important, and what to do when it's not working for them. So, I think from a human rights perspective, from kind of an ethical perspective, the issue of communication to patients is critical, but it's also important from a public health perspective, because I don't think we're ever going to get to really making sure that we have the adherence that we want to see if we don't start taking a more patient-centered, family-centered, and community-centered approach to care and to explaining about TB treatment. So I would love to see kind of a revolution in TB clinical care where counseling is given as much importance as it has been in HIV.
Yeah, Erika, I just want to reiterate that really from our experience in our project here, our our DRTB component of the MSF project in Kailicha is split into two sort of equal halves. The one half is what I manage, the medical access to drugs part, but then the other half is the patient support section. And we have a whole manager and her patient support team who really focus on what interventions need to be put in place to assist patients to continue their treatment. I mean, there really is no point us doing all the work we're doing on advocating for new drugs, advocating for better diagnostics, to screen more people, to get the correct diagnosis, to get them onto these amazing treatment regimens, if they're promptly just going to, you know, forget to take them or not really be empowered or understand why they're taking treatment and what exactly the treatment entails and what kind of things they can expect, you know, what challenges they can expect taking the treatment. And our patient support team have really done some amazing work in putting together counselling tools which are available on the MSF website, where it sort of very clearly outlines the kind of steps you need to go through in terms of counselling intervention. So right at the beginning, on the day they start their treatment, a second follow-up counselling session a week later, and then a home visit to make sure the family are involved, that they're educated, that infection control practices are learnt. And the counselling approach takes a very similar approach to what we use for HIV patients here, in that it's identifying exactly what challenges that particular patient has. So it's not this very generic, like, you must take your treatment, otherwise you will die sort of approach. It's more like, what is it in your life that will make you want to take this treatment? Like, what are your 3 incentives for continuing treatment? Why do you want to live and survive this disease? You know, it might be for your children, it might be for your job, whatever. And what are the reminders you can have every day to make you want to take your treatment? And how are you going to remember where to store your treatment? How are you going to remember to take it every day? So all of those kind of steps that really the patient can take on as their own responsibility are super important. It's not just about getting newer drugs with better regimens, because we're never going to get to a situation, not certainly in my lifetime, where you can just take a week of treatment.
Yeah, I feel like we are running out of time, and the thing is that we have 2 unaddressed questions, and we would like to highlight that all the presentations and the questions and answers will be available online, the recording of it, and we will be sharing the email from Erika and Jennifer so that you can ask your questions directly in written. And the last questions, if we are still able to catch them, are: what is the realistic timeline to control TB tentatively? And the last one is antiemetic drugs, metoclopramide and ondansetron, and its QTC prolongation when used together with bedaquiline. Is there another alternative as an antiemetic drug?
Erika, are you going to go for the first one?
Sure, I'll go for the first one, and I'll let you handle the antiemetic.
Okay.
So I think this question is about, you know, ending TB at the epidemic scale. Just to make sure, if we're talking about, you know, within an individual, there are good data to show that, you know, within probably a few days, but definitely within a couple weeks of being on effective treatment, a patient is no longer infectious. So they still have to follow up treatment and make sure, you know, that they adhere so it doesn't relapse. But in terms of, you know, controlling TB at the individual level and making people unable to transmit, this happens very quickly, which I think is really good news in terms of fighting stigma and making people, you know, not feel as isolated as they do often when they're on treatment. But of course that requires effective treatment. In terms of the realistic timeline to kind of ending TB as a global epidemic, and I don't like the word control. I think that we need to move beyond TB control, even though that's a very commonly used word. TB is preventable and curable, and I really think there's no reason why we shouldn't, you know, have the epidemic far under control now, but also really be making steps towards elimination. The WHO targets and then the SDG targets are between 2030 and 2035 for ending TB. A lot of countries could be making a lot more progress today if they just scaled up existing tools. There is modeling to show that, without new tools, and this is why the research is really important, we won't be able to kind of rapidly get to kind of the zero targets, the ending TB targets altogether. So I think it's kind of a mixed question. I think in terms of what we could be doing to do better on the epidemics, that can happen immediately if we just scale up the tools that we have now that we know work for preventing, diagnosing, and treating TB. And that would require having a lot more political will and a lot more finances for TB programs than we do. But then, in terms of the longer run, I think to really kind of end TB, it will take a bit more of a long-term effort. But I think, with the rate we're going at right now, we're never going to end TB. But if we can all push policymakers and push companies to invest more and push everybody to do better, I think it would be realistic to end TB by 2030 or 2035. But we need to really change the path that we're going on, and we haven't seen much signs of radical change. We've seen a lot of change in the rhetoric, but not a lot of change in action.
And just for the question on the antiemetics and QT prolongation, there are so many drugs that prolong the QT interval, and realistically trying to get doctors on the ground to avoid every single one is very difficult. I mean, we already see in our setting people use haloperidol and amitriptyline, which are known to prolong the QT interval when they're treating patients with bedaquiline and delaminid. And I think it's a balance of the risks and benefits, and if you feel like your patient is going to stop taking all of their treatment because they're vomiting, then use the antiemetic, but just make sure that you've got an eye on their QT interval and make sure that you're monitoring very, very well. But it's not like we can say, okay, don't use ondansetron, don't use metoclopramide. I think cyclizine as well, which is the other one that's sort of more readily available, also prolongs the QT. So there are lots of drugs out there, but it's about managing the risks, really.
Thank you. And another question, would it be possible to make cheaper the prices for bedaquiline and or delamanid through Unitad projects, taking into account the specific objective of making more accessible and affordable products for prevention, diagnostics, and treatment?
I just want to say I'm so impressed by the questions on this call. You guys are really thinking about stuff well, and I'm really impressed by it. I think that this is something that could happen in the future. I have to say I am a fully committed advocate for bringing the prices of bedaquiline and delamanid down. I think to be able to do that, there needs to be more scale-up of access to the drugs. There needs to be more demand. I think the best way to bring down the price of bedaquiline and delamanid is to get generics into the market. And there are generics that are interested, but there are IP restrictions, and I think it's kind of up to countries to decide that they might want to override those. But B, for price to come down, you do need kind of an economy of scale, and for generics to be able to kind of do this. And we really need to have more countries using the drugs. I think the other piece of this puzzle is that, especially for delamanid, which isn't widely registered, for a generic company to be able to have their product be used, they usually need to have kind of the originator product already registered to compare to. There are ways to get around it. You can import TB drugs using import waivers, but it's kind of slower and not ideal. So I think we need to keep the pressure on, regardless of what might happen with generics. We need to keep the pressure on for wide registration, and that can actually help pave the path for generics in the future as well. So I think the first step, and this might be something that Unitaid should help with, but the first step is really to make sure that more countries are using this, especially bedaquiline, which is available for free right now. There's really no reason why countries shouldn't be using it more. And delaminid, it is expensive. You know, it's $1,700 a course. I don't want to underplay that is expensive. And I do think that the price needs to come down, especially when, you know, bedaquiline is being given away for free. Countries aren't buying delaminid. But I think also, you know, even with the price being what it is, Global Fund funded countries in particular, most of them are underspending their Global Fund grants, and they could repurpose that money to be buying delaminid right now. UNITAID is funding a project right now called the End TB Project, which is aiming to scale up the use of bedaquiline and delaminid containing regimens, both kind of just in the programmatic setting as well as with a clinical trial that's looking at the different regimens containing either one or both of the new drugs. So I think depending on how that project goes, you know, they could be convinced to do further kind of scale-up work in the future. And I think that, you know, price definitely will be an issue, but even with what we're doing right now, we need to be putting pressure onto countries to start using these drugs more, and that will help bring the price down in the future.
For the moment, we are out of the questions, so if you have any, you have an opportunity to ask them for our participants. And I also would like to remind you that we will have the recording of the webinar online. I would like to thank everybody, and especially to our presenters, Erika and to Jennifer, and to all of the participants for the thoughtful questions. Thank you, everybody. Thank you, Christian, for organizing this for us.
Thank you for having us.
Thanks, everybody.